Okay, everybody, welcome to another episode of Mondays with Maishi. It is Monday night, November 3rd, 2025, and tonight we have the honor of hosting and featuring Elan Javanfard from Los Angeles, California, where it's actually already dark, even though it's very early. Um, Elan is a marriage and family therapist out in Los Angeles with a really, really interesting niche, I guess, in the area of suicidality, uh, prevention of suicidality, and really, really expert in suicidality. Elan also gives lectures and talks all over. I see his name plastered all over the place, and I believe teaches in a number of universities. Is it one or two?
Two
Okay,
at this point.
two at this point. Okay, so Turo is one. So many of you might know him. Um, Elan, thank you very much for joining us tonight and speaking about this very important topic, especially in light of more and more incidents that seem to be, I don't know if they're happening more often or if we're just hearing more and more stories in the Orthodox community, unfortunately, of people taking their lives. I know that in my career, there's a number of individuals that I know professionally who at some point did take their lives, unfortunately. Some of them were directly my clients, some of them were family members of clients. And in one case, we actually saved the life of somebody who was about to take her life. And
Wow.
so this is something that's very, very sensitive and very important, and an area where so many of us become panicky that it's really difficult, to begin to distinguish when somebody says, "I wish I was dead," and to start knowing when to have heart palpitations from that versus when somebody's actually really serious and what some of the guidelines and how we should see this. So I'm glad that you agreed to join us and give us some guidelines, and then also maybe we could talk about some more facts and figures of suicidality, suicide rates, risk factors, and of course, prevention and safety. So thanks for joining us. Tell us a little bit about, first of all, who are we talking to tonight? What's your background? What's your history? And how did you fall into this niche?
Yes. First, thank you for having me. Thank you to your audience as well for participating and listening. So as mentioned, I'm Elan. I live in Los Angeles, born and raised in Los Angeles. Only left Los Angeles really to go to uh, undergrad, where I did my undergrad simultaneously while living in Israel while being in yeshiva. So half-time rabbinic school in essence, and half-time undergrad. Came back to Los Angeles to do my graduate school at Pepperdine University
Great. So
with
by the way, if
the
you ever want to know where New York is, just send me a text and we'll figure out how to get you here.
been there a few times, come there frequently for speaking engagements, but very happy with the weather that we are experiencing in Los Angeles. My plan and my intent was to go into the field of autism and be an autism researcher.
Cool.
I started out as a autism researcher and I published research in fantasy and gaming for young adults with autism, and also was doing a research study looking for genetic markers in autism. Very like niche area of life that has nothing to do with where I'm currently at, but we put babies under functional MRI machines to look to see if we can find a genetic marker to autism based off a family history of autism. At the time, my plan was to go and get my doctorate in applied autism research, but I had a faculty mentor who told me go and try community mental health so you get a feel for something completely different in the field before you decide to take 7 years of your life to go get a doctorate. So I found the closest community mental health center to my graduate school and I applied and they asked, "What are you interested in working with?" I said, "Kids and developmental disability." Or family. I'm classically trained as a Gottman therapist as well through the Gottmans themselves. Um, and they said, "What are you not interested in working with?" I said, "I'm not interested in working in crisis. I'm not interested in working with people with personality disorders. I'm not interested in working with young adult women as well." You flash forward 13 years later, I specialize in suicidality and borderline personality disorder in women who are 16 to 25 with a history of cutting. Like the exact population I said I never wanted to work with is the exact population I continue to specialize in. And that's because the agency in Los Angeles County that I am now in a executive position within, we operate the Suicide Prevention Center for the state of California. So just for your audience, for people who may not be familiar with this, anywhere in the United States, if you dial the numbers 988, that is the suicide hotline. It used to be a longer 800 number, but now if you just dial 988 from your cell phone or landline, wherever you are, it will geotag you to a suicide prevention center and someone will answer, a trained professional answer, and talk to you. That either works for you as a person who is living with suicidal thoughts and you need help, but it's also a good resource line where therapists and clinicians call frequently to consult about people they're working with who have suicidality, and 988 will help them.
Cool, no kidding. That's great. That's great information, actually. Dial 988 as the professional, and you can get guidance. I want
Yes.
to share that information again a little bit later in the show, as people, as the participants continue to populate. So let's remember to do that. And I do want to ask everybody, for those of you who are here, please, if you can turn on your videos, we always love to see people and feedback. Chai is always so gracious, and she does it every week. So she needs some classmates to please participate. So if you can turn on it's not too late, and you may be in Los Angeles or still wearing your clothes and makeup, please turn it on. Okay.
No one told me I should wear makeup for this. I forgot to put my hair on also, so I
Yes, and so
apologize.
did I. Thank you, Rachel. Okay. So wow, so you ended up there, and then I guess you liked it. Is that what happened?
Yeah, it just I the two things happened. What I realized was that graduate school was the breeding ground of fear when it came to crisis. And I realize this now as a faculty member who teaches in graduate school as well. Graduate school scared me in working with crisis. The few things I remember from graduate school were document, 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 consult, 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 and it always related to people who were in crisis. And I always remember feeling in graduate school, if you don't document appropriately and you don't consult properly, you're going to get your license revoked or lose your license because someone's going to die or something, a crisis is going to occur and it'll all be your fault.
Right. And by
It
the
was
way,
this,
that's the answer to most of the questions on the test, if you're getting on your licensure test. So there, if you need a crash course, it was right there.
and that is part of where a lot of the fear comes from for many professionals with working with people who have crisis. The fastest way for anyone who's like brand new in graduate school and wants to open up a private practice, the fastest way is to find every therapist within a 10-mile radius of you, call them and say, "Hi, I will treat borderline personality disorder, narcissistic personality disorder, and active suicide," and you will get a full caseload in a week. Because most people who are established tell themselves two things: either leave that for specialists, or why do I need the liability and risk when there are so many other areas of clinical concern that people can work with, like
Mhm,
trauma or anxiety disorders or whatever
mhm,
it may be. And what I realized was that it wasn't that I was afraid of the population, it was that I didn't feel like I was adequately trained to work with that population.
mhm.
And once I received adequate training and I started going down the path of having more training and more consultation and more support, I started to realize, weird to say, that I was good in that space more than I was with somebody who had baseline anxiety or depression.
Mhm.
Like, give me somebody who has a fear of flying versus give me somebody who's actively cutting and bleeding in my office. I will take the cutter 10 out of 10, and that's the place I will do the work. And it just seemed that I was able to work well and navigate that edge of clinical space that many people struggled in being within.
So Elon, could we segue straight into some questions just based on that last statement that you made? Obviously, obviously for someone who's inexperienced or someone who's still in that space, that they're afraid of a cutter, somebody who's engaging in self-harm, somebody who's thinking or threatening something beyond self-harm, right? You obviously have a different perspective, or I should say, perhaps a different conceptualization of what it is that this individual is experiencing. Give us a little taste of how you might conceptualize this person's present experience as they are actively engaged in cutting or thoughts of self-harm or thoughts of suicide? What do you see differently?
I think the fundamental way that I see this differently, and many people who are in the field of crisis see it differently, is that all behavior is a coping mechanism. So all behavior is a coping mechanism. Self-harm, cutting, non-suicidal self-injury, or suicide is a coping mechanism. Now, we identify that it's a maladaptive coping mechanism. It's not a healthy coping mechanism. But to the person, they view it as the most logical decision and choice based off of the current circumstances they're experiencing. And if we start to think of ourselves clinically as it is not our job to remove suicide as an option, it's not our job to remove self-harm as an option, but rather it's our job to help the person identify that there are other alternative coping mechanisms available to them, then some of the onus of responsibility is off of my plate in terms of crisis. Because we start to discuss things from the lens of how can I give you new things? How can I provide you new coping skills? But the moment I first validate for the person saying, I completely understand why during this current situation you're experiencing, you might want to die by suicide, that validation itself cuts completely through, no pun intended,
No pun
and
intended.
allows you to minimize some of the distress that the person is experiencing. All behavior is coping. We just want our clients to learn adaptive coping rather than maladaptive coping. That's part of it. The other part of it, which I didn't get in grad school really that frequently, is that we don't realize how common this is, and we don't talk about it that much. So we don't talk about how approximately 1% of the population in the last year above age 18 has made a suicide attempt at some point in time. 1%. That's pretty high. We don't talk about how 6% of the population in the last month has had thoughts of suicide. We don't talk about that research that comes from the CDC. We don't know that about 1 in 5, 20% of high school students had considered making a suicide plan at some point in time in 4 years of high school. Now, we might start to say to ourselves that these numbers are specific to the general population. They may not be specific to certain cultural groups or populations, but we kind of have to start to dispel ourselves of that myth. We're realizing that it's exponentially on the rise. I wrote the statistics down because I wanted to be certain about this. But in the last 20 years, for the age groups 10 to 24, youth, suicide has risen by 62%. It's a 62% increase of suicides in the young adult age groups. And we've seen a 30% increase in the same time period of time, the last 20 years, for adults. So it is common. It is happening more frequently. And it is happening at high intensity. And the reason that this is important is because the moment we start to identify that it is not rare anymore, it is not just something that happens once in a lifetime in certain communities, we actually have to learn a little bit more of an empowerment around how we can validate that a person will even live with those types of thoughts.
Hmm. Okay, so I'm curious, just stepping away for a moment, let's say from the suicide part of this discussion and going more to the validation piece, because the objective of creating this show, Mondays with Moshe, was really to talk about therapy. I'm just curious if you can explain how you understand the mechanism of validation and how validation actually calms people down to the degree that it takes the edge off. How do you understand validation to do that? What's its working mechanism?
It's a great question. So, as a DBT therapist, I define myself as a DBT therapist. I also see myself as a DBT person in life. I think everything can be viewed through a little bit of that lens. Um, as a DBT therapist, we know that validation plays a large factor in clinical care. One of the dialectics of DBT, so dialectics meaning two things that can be on opposite ends of a spectrum that have to balance with each other, is this concept of validation and change, or acceptance and change, is really what we call it in DBT. It's this idea that you're doing the best that you can and you can do
Can do
better.
better.
Many of us have heard that. But in DBT, validation has a function, a real important function. Validation is the mechanism to lead to change. You validate so that you can offer and suggest change. The classic example I like to use is the example from Mary Poppins. I don't know if people are familiar with Mary Poppins, but they're maybe familiar with the song. Just a spoonful of sugar helps the medicine go down. Validation is a spoonful of sugar. Change is the medicine. If you want the person to accept the change, you got to give them a spoonful of sugar. If all you do is try to feed them the medicine, they're going to revolt and not be interested in. And if all you do is give them validation without change, that is also unhealthy. That leads to what is defined as bad therapy. So you have to do these hand in hand, one plus the other at the same time. And one of the fundamental assumptions DBT has about suicidality is that suicidal individuals' lives are unbearable as they are currently being lived, and that is why they are suicidal. So you
And
understand,
they can't reconcile the conflict of living and the pain that it's causing them.
right? And therefore, in their eyes, in their mind, suicide is the current only option of food that they have available in front of them. It's the only plate they have. It's their little empty plate in front of them. My job as a therapist is not to take that plate away from them. My job is to introduce them to the buffet. What are all of the other options that should be available to you other than just this one plate?
So,
That is
so
validation.
when you're engaging someone, when you say that is validation, that sounds like that's more than validation. That's beyond validation. First, there's the validation, and then there's the list of choices of what I guess the person is a bit calmer and they're a bit more receptive. So now there's a list of choices or options that they can engage in as an alternative to the self-harm behavior.
Yes. And only once the person has shown you that they've accepted your validation should you then offer the change. If validation is not accepted or they feel it is invalidating, then you cannot offer the change.
Okay.
And it's not up to us as therapists to say, but I validated them. I tried to validate them. If they say it wasn't validation, it wasn't validation.
So that's why you have to be a good therapist before you do interventions. You have to be able to recognize and be able to identify with the nonverbals and the messages and the energy that's coming across from the client or the patient to the therapist and recognize now you've received it. Now you seem more at peace. Now you're calmer. I didn't just do a checklist behavior by validating you, but I've got it in a way that it metabolized and you digested it. You seem calmer and more receptive. Now we can work into the intervention.
Right. And I think that's relevant across the board, whether it's crisis work, suicide work, or any form of therapy.
Well,
That
I mean,
we,
okay, so that really depends on, I think, on modality. I don't think that I would characterize how I understand validation in therapy the same way that you would, although it does have that benefit. But I don't know
right.
that Rogers would actually characterize the value or the purpose of validation in that sense. I think some might see validation in and of itself as a cause for change within a person. So, but
Correct.
that's
Correct. And correct. And I think that's where we get into the nuances of modalities, because one of
mhm,
the other assumptions DBT has is that the most validating thing a clinician can do for a client is to help them change.
mhm, mhm, mhm. And I think Rogers would argue that the better the validation, the more the change will happen on its own.
Right.
Mhm. Good stuff for a different week. We have too much to do on suicide. I did have a question about this though. I guess for a long period, for a long time, certainly before I was a clinician, my mind held a visual that suicide was like the brink of the highest level, crossing the brink beyond the highest level of depression. So that means if one were to say that they were depressed 98% or at a 98 out of 100, and the other one were to say they're depressed at a 99, the one who says they're depressed at 100, they're the one who's going to commit suicide. I wonder if that's a myth or if there's truth to that. Is it a degree of depression and helplessness, or is a person's choice to take their life coming within a completely different framework where they're sort of overcome by the devil or overcome by something very intense that doesn't necessarily relate. Because we've heard people say people have taken their lives when they really seemed calmer. They seemed like they were at a better place. Last week they seemed terrible. This week they seem much better. And before you know it, they're gone. Right? What is the phenomenon? What's really happening within a person's mind, psyche, experience that pushes them over the edge?
It's very interesting because I'm gonna tell you a really interesting stat piece as a impetus for sharing an answer. Um, One of the most common times a person will make a suicide attempt is 2 weeks after their antidepressant medication has started to kick in.
Hmm.
And we know that, and it's not, and that suggests that it is not directly related to the level of depression. There is something secondarily to it. Because had they been at the highest form of depression, they would have been so vegetative and so a, avolition. They wouldn't have any kind of interest at all, that they wouldn't have the energy to make the attempt. 2 weeks after their medication kicks in, they have a little bit of an energy boost, which gives them the opportunity. So what we know is that suicide runs, I would say, parallel to certain diagnoses, but it isn't necessarily a grade or a gradation of diagnoses. So it runs parallel to depression. It runs parallel to bipolar disorder. It runs parallel to personality disorders that are classified as cluster B, borderline, narcissistic, histrionic, those antisocial, when those people's needs are being threatened. It runs parallel to those things. It does happen most, and also, sorry, to PTSD as well. It's not like it's a level of those things. It's a function sometimes of those things. You can have major depressive disorder with psychotic features. You can have major depressive disorder with suicidal features as well to some capacity. It's not that you live your life at 80% depression, and once you hit the 90% threshold, suicide becomes an option for you. Because people can live their life miserable forever and never want to think of suicide. And other people can live their lives somewhat reasonably and somewhat normative and also consider suicide as an option. So it somewhat runs parallel to it. And I think it would be interesting to just share a little visual of what the evolution of suicidal thoughts could look like for people. So if
Okay.
you're comfortable with it, I'll just pull up on the screen for a second um, some slides that I've used in different presentations related to suicidology. But let's look at something like this briefly, obviously,
Okay.
as well. So you have a person who what leads a person to thinking or considering suicide? That's kind of what you're asking. Where does it come from? How does a person go from living functionally in their life to considering suicide as really their only option for their pain? So you have this individual who's living on their typical normal path of life. They have things that they're looking forward to, they have things that stress them out. What happens to you as a person when your stressors start to pile up? Work, relationships, stress, family, health, loss, identity, mental health, all of these things. What starts to happen is the person starts to experience some kind of restricted perception of the future. They're struggling to see what the future will look like. They're struggling to see what's in front of them. So when all these stressors start to pile up, what happens is the person starts to become overwhelmed with stress and they go into this one specific function. It's called tunnel vision. Many of us have heard of this term, tunnel vision, before, clinically speaking. But they're classic hallmark symptoms that are precursors to suicide that I think would be really interesting for us to talk about and the audience to hear about. Because in grad school, the things we usually hear is helplessness and hopelessness. Those are the things you assess for. You hear a lot about that. But there are precursors to helplessness and hopelessness. One of the classic precursors is something that's called mood congruent memory. Mood congruent memory. The idea of mood congruent memory is that when you are feeling a certain emotion, you will start to only access other emotions associated with that feeling. When you're feeling depressed, all you can think about is all of the other unhappy times. When you're feeling positive, you start to feel and think about other positive memories. It's the classic reason why you can live your life as a mature grown-up, but the moment you run into your friends from high school or middle school who you haven't seen in 20 years, you kind of act like a teenager for a few minutes because you just fall back into that pattern. So these clients, they have mood congruent memory. They're really only seeing their mood for the future based off of what's already happened to them. And they start to experience burdensomeness. They feel like they're a burden to other people. One of the classic symptoms of suicide is feeling like you are a burden to other people, and it's really difficult for you to actually socialize. After time, this person starts within their burden to feel what's called entrapment. They feel stuck. They don't feel helpless yet, but they feel stuck and they don't feel like there's any necessary way out. After that, helplessness and hopelessness sets in. And this is when we usually, as clinicians, start to hit the alarm and think, oh my God, something may be going on with this client. Helplessness and hopelessness will come. And after helplessness and hopelessness, the person will start to experience what is called psych ache. Psych ache is the physical manifestation of psychological symptoms. It's when your depression is so heavy that you feel it in your body and your bones start to hurt. It's when your sadness is so miserable that you feel it in your body. The classic example of this that many of us are familiar with is something that's called Takotsubo cardiomyopathy. I don't know if anyone's ever heard that term before. Many people know it in its vernacular sense, which is called broken heart syndrome. Broken heart syndrome is the cardiological disorder where, due to immense amount of stress, the flaps in the heart muscle stop working. So stress literally can lead the heart to stop working, and a person can die from a broken heart. That is psych. Now, once this cycle starts to begin for a person and they start to spiral into some sense of their reality being these items, the next thing that happens instinctually is they start to have a preoccupation with death. A preoccupation with death comes next. So it's not that the death is something that's on their mind. It's not that suicide is on their mind. It's that if everything in the future looks terrible, they feel like they're a burden to everyone around them. They feel trapped and stuck. They feel helpless and hopeless, and their body is constantly in pain, emotional pain. It's understandable why they want to die and they don't want to live anymore. Now, this isn't a linear process. It isn't like this leads to this, that leads to this, but these actually do have a little bit of connectivity to each other. That we start to see that as these symptoms begin to remain with an individual over extended periods of time, they don't get help for them. The preoccupation with death or suicidal ideation starts to find its way and creep in to the person's experience.
Wow. Wow. So I hear you saying that at some point a person feels like a burden to others, which is presumably when they begin to socially isolate. And when they socially isolate, then they feel that sense of aloneness or loneliness that's talked so much about, that as being sort of the worst feeling of being alone and with oneself. And then it's sort of a downward spiral from there.
Yeah. There's a famous suicidologist. His name is Thomas Joyner. Thomas Joyner wrote a book called Why People Die by Suicide. It's a seminal work that was written in about 2007. Thomas Joyner posits this model. I mean, he doesn't like the term. He calls it the interpersonal model for suicide. We call it the Thomas Joyner model. It's kind of weird to call something after yourself, but I feel like a lot of people do that.
Mhm.
The Thomas Joyner model, which I think your audience would enjoy the visual for this as well, is very much this. There are three things that lead to lethality within suicide. So people can live their life with some sense of suicidal ideation. That's just part of natural living. You wake up in the morning and you say to yourself, I really wish I just didn't wake up today because I'm so overwhelmed. I'm so in grief. I'm not going to do anything to myself, but if I didn't wake up tomorrow, that would be okay. If satellite fell from the sky and hit me, whatever, no big deal. That's passive suicidal ideation. But the Thomas Joyner model stipulates that there are three components that simultaneously can lead to lethality. Component number one is that a person has what's called a thwarted sense of belongingness. I am alone. I feel alone. Component number two is they have what's called perceived burdensomeness. They feel like they're a burden to other people. And component number three is going to be that the person has access to means to make an attempt. So the capacity to die, they're not afraid to die, is something that they have. What he says, and has shown through research that is really chilling, is that over extended periods of time, when a person only has one of these, two of these three, which is they feel like they're alone and they feel like they're a burden for a long period of time, the thought of I am not afraid to die will happen as a result of those two other symptoms. These two symptoms will lead to the third without intervention. A person cannot sit in the space of I'm alone and I'm a burden for such a long period of time without the next thought becoming over time, I'm not afraid to die also. That is the model
Wow.
he shared, which was really, really powerful because the short answer, which we didn't get to in a question yet, which is going to be how do you treat this,
Hmm.
is really what you see on the screen. You treat the sense of belonging, you treat the sense of burdensomeness, and you treat the lethality, remove lethal means. For example, if you know your client's alone constantly, getting them to socialize more or increase their social support, increase their social network, or see you more frequently is a big part of it. If they feel like they're a burden, start giving them roles or responsibilities or help increase their roles and responsibilities so they're no longer a burden, but they're a net positive to society. And remove access to lethal means. At any point in time, if you're a clinician, especially if you're a private practice clinician, there is no reason why on your initial assessment with a client, you shouldn't be able to feel comfortable asking a very basic, simple question. Is there access to firearms in this home? Do you know that about your clients? Does it matter now? No, but why not know the answer to that question on your basic intake assessment? Because just having access to a firearm in the home increases lethality
Hmm.
and increases the likelihood of suicide. So why not just know that in advance so that you can help be proactive if you need to?
Fabulous. If anybody has questions or comments, you can please hit the React tab on the bottom of your screen, click the raise your hand button, and we'll be happy to call you. I want to ask you about genetics, Elon. Uh, what role does genetics play into suicidality, or do we know? And how about learned behavior from parents who may have struggled with depression, um, or may have struggled with suicidality in the presence of a child or in the vibe of, the nonverbal presence of the child?
I'll take both of those. I'll start with the genetics part. What I'll
Mhm.
start by saying with the genetics part is my wife is a genetic counselor. I will defer to her for all genetic questions and comments for the future, which means after this, I'll ask her. But from my understanding of what we've seen, genetics plays a factor in mental health, and there is family predisposition for things like depression.
Right.
So depression can have a family predisposition. Um, the other component of that, whether you want to call it nature or nurture, is if you live in a household where somebody else died by suicide, then that could either be the nature of the individual or the nurture of what you grew up with as well. But we do know that suicide has contagion to it. Contagion means that when one person dies by suicide in your vicinity and no immediate intervention or discussion of that happens, that there could be more suicides that will occur because it now has become a openly accepted option. We see this commonly as what we call suicide clusters. You have one kid in a Jewish school who dies by suicide and everyone else hears about it, and we then hear about another case of another kid who dies by suicide. And that's because that contagion leads to it being something that one other person was the first person to do it. It's now a little easier for me to engage in that. Impulsivity plays a factor, but it's less impulsive in decision making once you already know somebody else may have experienced it. So there's a little bit of both. There's the component of the genetics of the depression, which definitely exists, and there's the component of the nature or the nurture of what you see in your environment. The one piece that I do think is important to take into consideration in terms of the genetic part of it, or the predisposition in a family or a home, is there something that we in the space of crisis work are aware of, which is called double depression. I don't know if anyone here has heard of that term before or knows what double depression is. It's not like winning double jeopardy. It's not a good thing. What double depression means is that a person has major depressive disorder and simultaneously they have a persistent depressive disorder. They're experiencing two forms of depression at the same time. Major depressive disorder is episodic. You have it for a few days or a week or two, and then a person comes out of that shell or that hole. And persistent depressive disorder is like a lifelong or 2 year experience of just low level of depression. Double depression is when a person has both simultaneously. They're constantly living at a low level, and sometimes they even dip further down. That person has risk of suicide in their very low dips because their baseline is already much lower than yours and mine. Does that make sense?
In
I
other words, they
know,
can't feel good or happy ever.
right.
So
I know I can get back to this baseline. They may not get back to that baseline. A household which has a family member or a parent who experience that form of depression, their children are at immense risk for experiencing depression later in their lives as well.
even just from the nurture factor, you mean?
Yes,
Not
from
necessarily,
seeing it.
not just because the energy level in the home was always low and dysthymic and like that.
Yeah.
Hmm, fascinating. So we have to be more positive and bring more energy into family life.
Well, we do know that there's approximately like a either 5 to 1 or a 7 to 1 filter that many of us feel in our own lives. And what I mean by that is for every one negative thing I tell you, it's going to take 5 to 7 positive things to counteract that. So same goes with this kind of space in our homes. Like one negative thing said to a child lasts just as long as 6 or 7 positive things would have. So we have to counteract it by being immensely positive so that we can negate the negative that's there too.
Okay. Again, if anybody has any questions, please hit the React tab, raise your hand, and we'll take your questions or comments. I want to jump back to something you said earlier that struck my fancy. You talked about suicidality being very much connected with what was once called cluster B personality disorders. And it got me wondering as to how much that's related to depression versus, let's say, acute paralysis from anxiety. So if we look at, I don't know, like narcissism is really steeped in depression, but there's probably a tremendous anxiety component to that depression. The anxiety of being exposed, or the anxiety, in borderline personality, there's a tremendous amount of anxiety that's being covered through some of these behaviors. Is there room to argue or to understand the phenomenon of suicide from a more acutely anxious, like I can't manage my life, I can't handle the degree of pressure and tension, or the fear of being exposed, or the fear of being judged, or the fear of being ashamed? And for that, one would take their life over more the depressive, I just can't handle the pain of depression.
We didn't practice this in advance, but I have a specific slide for this. That I think would be a really good thing to share with your audience, and I think it will speak directly to what you just said.
Okay.
What I'm
This is
sharing
a
with you
question that
now.
that's always bugged me. Is it so related to depression as much as a person who's just so overwhelmed that they can't handle their feelings? And it's like, I can't deal with this anymore.
So what I'm sharing with you now is what's called the functional model of suicide. This was posited early in the 2000s, and then again, it's been reinforced in the last 5 and 10 years again. What you're seeing here is the four common reasons why a person makes a suicide attempt. You're seeing also the 4 reasons behind a person engaging in self-harm behavior as well. So what they are is going to be two that fall into the category of positive and two that fall into the category of negative. Positive does not mean good, negative does not mean bad. We know this is reinforcement. Positive means it's adding something, negative means it's taking something away. And you also have the categories of internal versus external. So these are the categories of things that are happening for themselves and things that are happening socially. So let's look at what you just described. Person may make or engage in a suicide attempt or engage in self-harm to add something desirable, to feel something in their life. When you can no longer cry tears because you're emotionally distraught or you're out of tears, you cry blood by cutting. You want to feel something. Another person is looking to let other people know how they're feeling, to get attention. I don't want to call this attention-seeking behavior. I have my own thoughts on that term, or manipulation as well. But this is to get something out of somebody or get a behavior or a need met. You
To
engage
elicit energy.
yes, that's a great way of putting it. To elicit some kind of energy or response. They're attempting suicide or engaging in self-harm. These are both positive. On the negative side, it speaks directly to what you just mentioned. To reduce tension or negative affect, to stop bad feelings, to not feel the anxiety anymore. It's so overwhelming. The flashbacks are so immense and overwhelming. I can't take it anymore. Suicide could be something that the person considers or self-harm. And then the last one is to escape interpersonal demands. Too much pressure, too much punishment coming my way. My marriage is crumbling. My family is falling apart. So everyone found out I was unfaithful. They found out that I lost all the family's
What about
finances.
debt? Yeah, debt. I just said
I
debt.
gambled money. I gambled. We see this. I see this frequently. If somebody finds out that somebody finally gambles all the money away, mortgage the house, and the family's about to find out they're going to be evicted. I have a policy that if I die, they get money. Suicide seems like a good option. To escape interpersonal demands. That is part of of this model. What we see in the research is that while there are four reasons typically that a person might engage in a suicide attempt, we can distinguish down this middle line a clear line of demarcation as to those individuals who make an attempt and survive, and those individuals who make an attempt and die.
Really.
And that line of demarcation is as simple as the people who are on the side of positive, the people who are looking to add something desirable or let other people know how they're feeling or get energy, are less likely to engage in lethal attempts, but they're more likely to make attempts. These people make more attempts. These people are more likely to die by suicide. The demarcation is also predicated on the individuals on the negative side are more likely to use a lethal means, such as going to the top of a bridge, using a weapon, or something along those lines. And these may be more likely people engaging in less lethal forms of means, like minor cutting or pill use as forms of that. So it's not about the depression per se. It's each of these things can be related to any other diagnosis that a person may be experiencing that is making them want to either add something desirable, gain attention, reduce tension, or escape some kind of interpersonal feeling as well.
Amazing. Wow, so clear. Devora, let's hear.
Oh, hi there. Nice to see you. My question is, I'm curious about you using the terminology of suicide when we're talking about self-harm. I've always been taught that like the self-harm behaviors are not actually suicidal. And meaning that the left side of the screen was those are self-harm behaviors, which is different than harm with intent to kill oneself. I'm wondering why you're putting both of them on the same grid versus saying this is self-harm, this is suicidality.
Great question. So, non what we call self-harm, or clinically currently is called non-suicidal self-injury, NSSI. So, non-suicidal self-injury is one category of clinical crisis, and suicide is another category of clinical crisis too. However, what you were seeing on the screen while I was sharing with you are the four reasons why people will even make a suicide attempt. Even that positive side can be a suicide attempt. The same will be the same four reasons why a person will engage in self-harm too. So a person will engage in self-harm to reduce negative feeling or to add something desirable. They'll engage in self-harm to gain something from other people or to escape interpersonal demands as well. So this model this four quadrants model, as we call it, relates directly back to individuals who engage in NSSI, non-suicidal self-injury, but it also engages on people who are experiencing suicide. Now, it is more common that people who are engaging in non-suicidal self-injury will live in the positive section that I just described. And it is more common when people are experiencing suicide as its highest intensity, they'll live in the negative side. But all four of these quadrants play out on both of those populations. It's a great question.
Interesting. Thank you. And your concern, one question further, just your concern as therapist, if is it our job to differentiate which kind of behavior this is? Is this suicidal intent and therefore this is a hospitalization, or is this a cry for help and this is, this is something where I'm paying attention to, I'm acknowledging the distress, I'm following up in a different kind of way other than I would if I would see this as an attempt.
Yes. So I'm
Okay.
answering yes to an extended question. And what I mean by that is, in the space of suicide, we didn't get to this, but it's a good time to address it. In the space of suicide, intent matters almost just as much as the attempt. Intent matters just as much as the attempt. So a person says, I can't take it anymore. I'm so sick and tired of my life. My life is terrible. And they decide to go into their bathroom and swallow 20 aspirin and go lay down and hope to never wake up. That's a suicide attempt. Now, 20 aspirin won't kill you. You'll have a stomach ache. You will maybe need some medical attention, but most likely not. But that still is an attempt because that person's intent was to die. A low injurious behavior leading to a lack of them dying does not mean a suicide attempt was not done. So you still have to try suicide attempt and go down the road of whatever you might want to do. Now, after it occurred, you might not hospitalize them. Depends on how long later you find out. But if it was right away, yes, you would hospitalize them despite the fact that it won't kill them. Now, on the other end of the spectrum, you'll have another person who will say, I'm not trying to die, but I'm going to swallow 20 Vicodin. That may kill them. They may die from that. That wasn't their role. That wasn't their thought. But at the same time, I'm still going to have to treat that as an attempt because that behavior may actually lead them to death. So the two factors that are important is what is the attempt and what is the intent? The intent matters because the intent is what is telling us, did this person think that this is what they were doing? And once a person breaks that threshold of their first suicide attempt, they're at risk for another attempt for 10 years. So for 10 years, they're still at risk for that next attempt because it crystallizes a memory in their mind. The example I like to use is what we call a flashbulb memory. So Moshe mentioned it early on. All of you who live in New York, who are old enough, remember exactly where you were on 9/11. You know exactly where you were. You knew exactly what was going on because it creates some kind of flashbulb memory in your mind. Like, I know that big event, what was going on. A suicide attempt is a big event for a person. And once they cross that first threshold of they tried to already take their life, every subsequent try will be easier because it's not their first time. So for 10 years, it's easier for them, and therefore they're still considered to be in the category of mild risk, unless there are other symptoms they have, which can increase their risk exponentially as well.
Thank you so much.
Wow. Okay. I have a question about what I guess I would call existential suicide. So, in other words, when we think about suicide, we think about people in severe emotional or mental distress, who are acting out of desperation and impulse, etc. Back in the day, there was a concept of sacrificing one's child or sacrificing oneself for a greater cause, for a God, right? Those were very deliberate, non-depressive suicides or homicides. So, are there people today who are living just in existential emptiness and they say, I don't see the purpose of experiencing joy or happiness because I experience a lot of pain, or I don't understand what there is to accomplish in life or what purpose there is. And as a result of just existential emptiness, very deliberately and calculatedly decide to take their lives.
Yes. And what's interesting is the person who did the most research in this area and posited the most thoughtful information, in my opinion, in this area is Viktor Frankl. Viktor Frankl's model. So, for the audience who may not be familiar, hopefully they are, Viktor Frankl was a psychiatrist who went through the Holocaust. He wrote a book, one of my favorite books of all time. It's called A Man's Search for Meaning. The book is written as two parts. Part one is his own experience living through the Holocaust, and part two is his conceptualization of the reality in the world predicated on his experience, called Man's Search for Meaning. What Viktor Frankl posits is that meaninglessness and existential emptiness are risk factors in suicide and can lead a person to not want to live life. So if you don't have meaning and you don't have existential belonging, then you are less likely to put energy and effort into wanting to live. So you can call that suicide, or you can call that just not wanting to live and allowing yourself to kind of fade away, or kind of, as he posits from people who experienced it in the war, wither away in many ways, that those two things can happen. It's also why within dialectical behavioral therapy, DBT, one of the fundamental tenets of DBT is not that it's a therapy model, that what you're trying to do is help a client create a life worth living. It's a sentence that's used frequently. Let's help you and let's help together create a life that's worth living. Because if your life is worth living, then you don't have that existential angst. You minimize that existential pressure. And if life is worth living, you can handle any difficulty that comes your way because it's just this bump along the road of long-term life. That component is really interesting. It happens to be that Marsha Linehan, who's the founder of DBT, her memoir, her own personal book that she wrote, the same way that Viktor Frankl wrote his book, is called A Life Worth Living. That's the name of her own
Mhm,
memoir.
mhm.
Um, so, like, you hear this, and you might hear this in your own therapy spaces as well. Things like, I feel like my existence is a problem. What's the point of living? What's the point of existing? Nothing has meaning. All of those are not necessarily suicide or suicidal. I might posit them as passively suicidal because the person is no longer putting action or intent into wanting to live their day-to-day life. But that existential angst that is happening, that existential feeling that the person has over prolonged periods of time, coupled with I'm alone, I'm a burden, may actually become the breeding ground, if we want to call it, for suicidal behavior.
Interesting. But for them, what if they say, I've already come to the conclusion that it's not worth living. You're trying to push me or encourage me or convince me or cajole me to create a life worth living. I've come to the conclusion that life is not worth living, and it's not worth trying to create a life that's worth living. Maybe because of those bumps in the road that will challenge me, or I'll have to face, or maybe because what is in it or worth it? What mission do I have, or what value do I have? So how do you reconcile I guess what we would call the therapist's agenda? Here we're talking about life and death, so maybe the therapist's agenda is a little bit more important. But how do we reconcile the therapist's agenda and when it contrasts with the client's agenda, which is I'm really fine not living and don't want to be told or pushed to live?
There are several components. It's very fascinating. I actually had somebody in private practice recently. I don't do a lot of private practice work. I do two cases at a time. That this is exactly what they were experiencing. And the thought, or something along the lines, you start with the validation. So it sounds like you want to die so much. It sounds like you're not, sorry, it sounds like you're not wanting to die as much as you just don't want to live, or you've identified that living is not something that necessarily you need to do. And when you start out by validating for that person that it must be that living is so difficult, so challenging, or has no benefit to you, I understand why you are feeling the way that you're feeling. That's step one. And if the person feels like you understand that that is what they're going through, some of the things that I might ask them are very basic and they come directly from Viktor Frankl. What used to give your life meaning? Is there any time in your life where you had meaning? Where did you feel like the most true self version of yourself? Is there any period of time where you had some values and those values have dimmed or gone away? Is there any message that life's pain is trying to provide you? Is there any message life's pain is trying to provide you? I would want to start with that perspective of what are some of these things? What are some of these reasons? What are some of these experiences? And what would it mean to have a meaningful life? Or what does a meaningful life look like? That's the area I want to be in for them. Now, as a person who is dealing with suicide, what I would say is that if they're willing to engage me in those existential discussions, I'm winning every time already because they're not dying. Every session, they're still alive. I am keeping them alive, or they're staying alive, and I'm winning my goal of lack of suicide. Are they thriving? Absolutely not. Are they clinically miserable? Quite possibly. But step one is getting them to feel like I agree and I understand that this is how they're feeling. And I'm not forcing them or cajoling them into it's impossible you're going to stay like this. You have to move forward. Because eventually, once I have built enough good credit with them, I'm going to start addressing the existential avoidance, which is something that is actually a part of this. There is existential therapy that exists. Existential avoidance means that you start to gently start to hit at, like, where did the loss of identity come from? Is there any fear of being insignificant? Do you have spiritual doubt in your life? Do you have any responsibility or sense of freedom that you feel more of or less of when you've already told yourself life is not worth living? You can't fail at something if you just aren't playing the game. There's power in that. That is really a strong driver for some people. I can't do worse if I don't care. So eventually, over time, you start to address the existential avoidance. That's part of that. There's a clinical model for this that really has shown to be effective. Interestingly enough, one of the most effective forms of addressing this is increasing spirituality, helping the person connect back to something that's larger than themselves as well. And if they're able to tap into that, that is really a fundamental aspect of resiliency and a protective factor for existential angst.
Wow, very nice. Okay. Leslie, you had your hand raised before. Did you still want to ask a question or comment?
Um, there's just so much to take in. I really appreciate you having this now, I think it's so important. And Moshe, you mentioned something that I've been seeing, and I wonder if other people have noticed this as well, this increase in existential angst among young people. I don't know, over the past year, I've had, people from like high school age up until, early 20s with this painful
What's the point of
existential
living?
angst.
I just don't see any purpose or any reason to live. Yes, I may have some pleasures and joys, but it's not worth it when compared to the pains
Yeah.
and the effort. And so why should I live?
And also, Lon, you spoke about something that I've heard, coming from a few of the patients, is that pain, that physical, emotional pain that they describe. Um, I don't remember ever encountering this in all the years I've been practicing. So many people in this kind of a space.
I could definitely validate and say that it's immensely on the rise. Existen
Existential.
Existential angst. Well, let's start just with anxiety and depression. That it's on the rise. We know that. It's almost a 40% increase pre-COVID to post-COVID, the amount of anxiety and depression people are experiencing. So we do know that a lot of that has started to increase. As the world becomes more polarizing, as life becomes more challenging to live in some ways, existential angst is also climbing exponentially. Um, you can
What about fear, the fears that media, social media are producing, especially, I mean, for sure in our community where, Jews are feeling So many people are claiming just to feel scared wherever they are and like in fear of their lives.
Not October, April of last year, I spoke at the American Association of Suicidology, their conference, and I did a presentation on the clinical implications of anti-Semitism on suicide. The clinical implications of anti-Semitism on suicide. I also spoke a little bit about a lot of cases of people living in Israel and soldiers and people who survive trauma making suicide attempts and increased cases of suicide. So we do know that that is exponentially on the rise. We do know that there plays that feeling like the world hates you, feeling like you are small and insignificant, leads to a lot of this existential angst, which can also increase or exacerbate a suicidal crisis. One doesn't create the other, but it definitely can be fuel for somebody who already has a little bit of that flame for the other. We are seeing that. We know that that exists. We also do know, on the other hand, though, that religiosity, spirituality can be resiliency factors. Those can be things that engaging in them effectively can be antithetical to depression and antithetical to suicide as well. There's a really cool research article from some group out of Japan that describes the concept of Shabbat, or 25 hours of self-care, as being a coping skill for depression. So we know that things like spirituality or social living can do that. But social media obviously makes it much worse because you always see the best version of other people and you're comparing that to your own day to day. One of the quotes that really stands out to me that I really love is, I think it goes something along the lines of, we compare our own thinking to other people's behaviors. So, for example, as a parent in the park, I'm looking at other parents and I'm like, oh my God, they're the best parents ever. They're so attentive to their children. They're doing such a great job. And I'm just sitting here thinking to myself, why can't my kid stop throwing sand? We compare our thoughts to other people's behaviors rather than they may also be thinking the exact same things and thinking they're struggling. We're looking and seeing the best of others. We give them the benefit of the doubt. We don't give it to ourselves. Social media makes that much worse. So all of these factors in life make all of these circumstances more challenging. And therefore, it is understandable. And again, it validates why we are seeing such a rise in mental health acuity and symptoms across all spheres of humanity, inclusive of our own community.
Oh, wow. Okay, let's take a question from Malky. Go ahead.
Okay, so I have two questions. First of all, the one I posted, that how would you change your intervention based on which quadrant you find your client in? How would it change how you would intervene or what intervention you would choose?
Great question. So a person who is going down the road of trying to add something desirable in their life or gaining some kind of attention or gaining something from other people, it's positive. The most common interventions directly for that person is going to be replacement. So replacement, how can I replace what you are wanting to do here for other things? The classic examples of this, let's do the example. I think I was talking about this with Devorah earlier. The classic examples of these are going to be people who are engaging in non-suicidal self-injury, cutting, for example. It's the most common one. What are the things that you can do as alternatives to cutting? I have a handout on this that I've used in different trainings in the past, but the most common alternatives are going to be, one, ice, taking ice and rubbing it on your wrists to feel a sensation of burning. Two, taking hot sauce. Pick your hot sauce of choice. Some hot sauces look and feel like the consistency of blood, and use that and pour that on your skin and watch that drip. Also, the sensation of hot sauce. I don't know if any of you have ever held a spicy pepper in your hand for 10, 20 seconds. You actually start to feel a little bit of burn in your hand. Those are also replacements. The basic replacement mechanisms will be things like rubber bands, snapping rubber bands on your wrist and feeling that. So that's going to be things that can fall into the category of positive. These are there's no therapist who treats suicide who doesn't have hot sauce in their office and red markers in their office at all times to replace blood as something that's a color. I carry hot sauce in my wallet. That's also because I'm Sephardi and like food needs flavor. But on the negative side, which is the opposite of what you described, the opposite end, to reduce the bad tension and to escape interpersonal demands, instead of just speaking directly to alternatives, meaning giving them an alternative mechanism, you want to delay. You want to delay. Your job there, your goal there is why now? Why today? You've been feeling distressed. You have been experiencing infidelity in your life, and your partner has known about it for a week, but today is the day you want to die by suicide. Your family has known for 2 weeks now that you lost their mortgage, but today is the day you want to make an attempt. What today is leading you? If I can delay you by a day, then I can start to create space between this decision and the decision that I'm going to hopefully get you to engage in more clinical care. Your job in that space is more to create distance between what would be perceived as the impulsivity of suicide rather than give them an alternative, because the alternative to them is meaningless if it is not going to solve their problem. It's just about delaying. Um, I mentioned this, I didn't mention this earlier here, but one of the things I used to do as part of my training prior to being married is I used to go out in the middle of the night and deal with people who are experiencing suicidal crisis. It's part of what we did. We'd go on bridges, rooftops, billboards, and I'd sit there and we talk to people who were suicidal. People would ask, like, what do you do in that moment? What's your job? How do you solve their problems? My job was not to solve their problems in any way, shape, or form. My job was just to get them to make it one more day. Just make it one more day. Like, why today? Why now? You've been miserable for 10 years. Why is Monday at 7 o'clock the time you've decided that is the end of your life? Let's get you to make this decision after you're sober, you had a full night's sleep, and your belly is full. And now see if it's a better decision. So it wasn't my job to fix their problem. It was just a delay. In the quadrant of negativity, you're helping them delay to engage in more experiences. In the quadrant of positivity, you're helping by offering them alternative suggestions. I hope that like kind of helps separate them out for you.
Well, that's great. Can you tell us a little more about the experience of crisis intervention that you engaged in, and maybe a couple of anecdotes that are really that personify the work of suicidal prevention?
Yeah, I'm wondering which way we want to go. We want to go the positive way. We want to go the light side or the dark side, and maybe we'll do a little bit of both. Maybe we'll start with light and dark and end with light. Um, First clinical case I ever treated, the first clinical case I ever treated in outpatient psychotherapy, the person died by suicide. So the first client I ever had, that was my own individual client, died by suicide.
Must have been great for your professional self-esteem.
100%. Imposter syndrome was not something I knew existed until that case. Now that person, it took me a while to realize this, and it took me my own conception of training to realize that there was nothing I could have done differently, even with 11 more years of training now than I had then, that would have changed the trajectory of this case. But in the moment, obviously, now to this day, that person's name, their social security number, and a lot about them is still imprinted to me. I still remember them. But I'm able to handle that, and therefore I continued in in that work. But a case that really I think resonates, and a lot of people would find this fascinating, is I got called out to the scene where there was a young woman sitting on a billboard. My job was to go and speak to her in a safe manner, in a safe way. So there was a safe way to get there so that I can still be there, where I was, I would say, like 5 feet away from where she was. Didn't know how old she was at the time, but it was clear that she was under 18. She was like a student to some capacity. So I asked the first responders on the scene, does anyone know anything about this person? Do you have any information? No, nothing. Has anyone talked to her? She hasn't said anything. People have gone over to talk to her, and no one has said anything to her. So as I sat down there, I started scanning her up to see if there was anything body language wise that I could pick up on. And what I realized was she had a backpack that was right there on the ledge with her. And on her backpack, she had a bunch of those sewn on or like ironed on logos of superheroes, different superhero characters. And I said to her right away, I looked at it and I said, and maybe your audience will be familiar, I hope they are. First thing I said before introducing myself was I looked at her and I said, Marvel or DC? Those are two comic book worlds. Are you a Marvel fan or a DC fan? And first word she said, she looked over to me like that to see who I was, looked back down and said, Marvel. That's it. Got one word out of her. First word. So I then started and went down the road of like, oh my God, I'm a huge Marvel fan. in my opinion, it's these two characters that are my favorite two characters. I'm a big Captain America fan and a big Iron Man fan. It happens to be I'm a nerd, so like I can talk these things with clients. Um, and I said to her, like, are you team Cap or team Iron Man? And her response, classic, like somebody who was suicidal, looked at me and said, neither. Oh, okay. So, what is your favorite superhero? I asked. And she said, Daredevil. It's a character. It's called Daredevil. Now, knowing what I knew at the time, I said to her, "Oh, that's awesome. Daredevil is having like a big revival recently in this in the because it's a TV show right now. Daredevil is on Netflix and people are watching this show. Have you seen it?" And she says, "Yeah, I've watched it." So then I asked her right away. I said, "Have you finished the show?" She said, "No." I said, "Well, if you die, aren't you curious how the show will end?" And she looked at me and it was like a little bit of a quirky smile. And she said, I hadn't thought about that. I said, okay, well, it sounds like you really like this show. You really like this comic book. And you haven't finished watching it yet. I'm wondering, do you have your phone on you? Do you have Netflix on your phone? Yeah, I do. Do you mind if we sit and watch a little bit of an episode together? We watched a few minutes of the episode. She started talking. Hi, my name is such and such. This is how old I am. Okay. How long have you been into Daredevil? How about you? I said it was one of my favorite comics as a kid. I loved the idea of who he was and what he was experiencing. So we started to open up and talk. And what I realized was that she was 17. She's been experiencing sexual assault by her stepfather for the last 2 years. She was afraid to tell her mom because her mom loves this man. It's the first man who treated her mom well. So this man never hit her mom, never touched her mom in a negative way. Every other man in the mom's life did. So she tolerated the sexual assault because she wanted her mom to be okay. She finally got to a place where she couldn't take it anymore. And she knew that she couldn't tell her mom because if she told her mom, it would blow up the relationship. But she also knew she couldn't handle it anymore. So the best way to not be a problem in mom's relationship was to die by suicide. That was her chain analysis for why she wanted to die. So I asked her, I said, I'm wondering if I can help you find another place to live for a little while we help you and give you some treatment. So we never had to tell. She was a minor, so we did have to eventually report and go down that path. That's a whole other conversation another time. But the client was willing to come off the ledge, got hospitalized, and I said to them, if you're interested, would you be willing to work with me in therapy for the next 5 weeks? And she said, yes, but why 5 weeks? I said, well, there are 5 episodes left in the season. I'm wondering if you can watch one episode a week and agree to live for 5 weeks. Yes, willing to do that. She engaged in that and said she's willing to do that. We got to the 5th week. I obviously watched ahead. We got to the 5th week, and I said, so now that the show's over, what are your thoughts? And her response right away was, you know they ended on a cliffhanger. There's obviously going to be a season 2. I said, yes, you are right. I already looked online. They've already piloted a season 2. There will be a season 2. And she continued in therapy ongoing to get the help and care that she needed. In that exact moment on that bridge and that rooftop, my goal was not to solve sexual assault. My goal was not to solve 17-year-old angst. My goal was not to treat her depression or existential feeling of how she's going to make her mom feel miserable. My goal was just to get her to tomorrow. And in crisis work, that's frequently what it is. It's not about the large picture of can I solve everything? It's about can I just get you to tomorrow? Can I get you to the next meal? Can I get you to the next session? And if I can get you to the next session, and the next session after that, and the next session after that, and the next session after that, then I'm starting to create a life that's worth living. That, I think, is a classic analogy or a classic story that really embodies the fear that we may have that this person's responsibility is on us, but at the same time, how small little things we do as interventions can have massive ripple effects in creating this kind of life that's worth living for the individual.
Wow. Shulam, you got to say that out loud.
So
My
my
favorite
favorite superhero is Elan.
That's very kind of you. Thank you.
Beautiful story. Thank you for sharing that. That was really
That's
touching.
beautiful. That is wonderful, wonderful. Uh, um, how do you say it? It's just a great paradigm of what this work really is. Okay, let's jump to Malky if we still have a few more minutes. Go ahead.
I just wanted to know, like, I see that I have some clients that come to me with such terrible stories and terrible lives. And the idea of suicide is not even on the table in any way. Terrible lives. And there's some that sit down in front of me and they're almost like casual about it. And I'm wondering your thoughts about that. Why some people wouldn't even make it to the table at all, while other people are just like, yeah, dying sounds like such a great idea.
It's not easy to quantify why some people think about it and why others don't, especially when you try to compare or contrast the level of distress they experience. But what we do know, and you know this as therapists as well, is that we really can't compare people's stories to each other. How they perceive or feel their story is different. That one person can objectively have a much horrible life, but be able to tolerate that better than another person who has a less horrible life and it's miserable for them. One person can break a nail and want to die by suicide. Another person can get hit by a bus and not in any way, shape, or form think that I need to die. We can't quantify that. There is no mechanism for determining, and this is something we know in crisis theory. Crisis theory tells us that there's no mechanism to knowing how a person will respond to a crisis based off of their adaptive coping prior to the crisis. A person can be living their life brilliantly, and a crisis can consume them and they'll be miserable forever. Another person can have multiple crises in their life, and another thing comes along and nothing happens to them. So we can't dictate or quantify that. What we can do is validate and not compare. So for the person whose life is not so miserable, and we know many other people whose lives are miserable, we don't want to compare. Obviously, you wouldn't. You'd be like, but so many people's lives are worse. Why would you want to die? None of us are going to do that, obviously. I know. But at the same time, we have to be able to step into their shoes and validate that from their lens and their view, what they're going through is miserable enough that they would want to die. And in that moment, once we are already in their shoes and can validate that experience for them, then we can start to provide them other interventions in terms of what are some of the other things that may make you want to live. The other person you mentioned earlier on, there are people who go through immense struggles and traumas and challenges in their life, but it really relates back to what we said earlier with Viktor Frankl. If they have meaning in their life, they're going to go through any immense amount of trauma. You have people who lived as hostages for almost 2 years and survived. They had meaning. They had purpose. They went through more trauma and more challenges than anyone we will ever treat probably has. And yet they are still standing and living. Because for them, they created some sense of meaning, some sense of purpose, some sense of identity associated to it. And maybe for some of these people, they've told themselves, it is never an option to die by suicide. It's not on the table. It's not something I'll think about. Whether it's for religious reasons, which people have, whether it's because there are people in their life who will feel more miserable if they're gone, whatever those things may be, they're going to keep living and taking the pressure because that just isn't an option for them.
Fabulous. Okay.
Thank you.
Elan, that hour has gone by so quickly. There's still so much that I'd love to cover and talk about and think with you, and you're so engaging. I really appreciate that you did this for us, and maybe we'll have a part 2 one day soon.
My pleasure.
But I really appreciate it. I'm very grateful, and this was extremely informative for me. A lot of takeaway points that were very valuable. So thank you very much.
My pleasure.
And
And
thanks
I know you
everybody for
mentioned
joining. Yeah.
I know you mentioned this earlier. I'll share it because if anyone's interested, I do quite a few of the trainings for Nefesh International online. There are quite a few of them that are coming up in the near future. I think over the next few months, there's a bunch of suicide trainings and DBT trainings and crisis trainings.